For our last talk, we had Eric Hekler from UCSD. He's a professor in the Public School of Public Health at UCSD and associate dean there. And one interesting bit of information is that Eric was actually in the very first class of Mobile Health Training Institute back in, was it 2012, 2011, somewhere there. And he has come a long way since then, doing really interesting work. He's one of my closest colleagues. I'm thrilled to be able to work with him on a bunch of stuff. And he's going to be talking today about sort of how to incorporate mobile health research into more sort of community-driven research while keeping an eye on what we can learn in terms of sort of deeper causal processes that underlie our interventions and how we can think about generalization and transportability given this sort of strong focus on communities. Eric, all yours.
Thanks, Pedja. It's great to see you all. I look forward particularly to connecting with members of my team. You know, I'm also a core faculty for this. So yeah, let's just jump into it. I'm going to try to give about 45-minute talk, and then at least, you know, given our timeline, we'll still hopefully have about 10 minutes left for conversation. So this talk is a lot more, is fairly high level. So it's really much kind of asking the question of like, what kind of evidence should we be producing and for what purpose? Okay. So that's sort of where we're going to go with this. I invite you to feel free to throw in questions and stuff into chat. I probably won't be able to answer them while I'm giving a talk, but at least we can keep track of them for later. And then particularly if we don't have time by the end, at least I can have a sense of it. So sorry, I'm just moving my little things around so I can actually see my screen. Okay, good. First, acknowledgements. You can see there's Pedja. He is, I literally call him my research spouse sometimes, so we are very close. But many others. I also want to give a shout out to Milim Kim, who I actually invited to join this. She's a postdoc working with me. And she actually developed some of the visualizations here that are core part of this and my funders. So I always like to start with my take-home messages and then say it a few times, just so like if you forget everything I say, if you can just try to remember these ideas, that would be great. One, thinking about this from digital health, and I'm using digital therapeutics in part just because I think that term is sort of getting buzz, but you know, digital health, mHealth, doesn't really matter. Digital therapeutics, community and population health, there's oftentimes this hope on what we hope we can pull off, but there's a gap on what we're actually getting from these. And I'm going to unpack that, particularly these 5 different layers of that. But this talk is really much more about asking the question, well, what should we do? And asking that from a very high level perspective. And the conclusions I want to try to invite you to think about and make an argument for is one, that I think we should be far more conscious about, even in our research and even when we're doing science, trying to focusing on helping people first. And we do that by taking advantage of trying to really focus on creating and optimizing interventions in partnership with communities and those serving resourced communities. And to do that, a lot of the methods we're talking about, particularly micro-randomization trials, as you were just learning about those, we can use those to actually try to build up what I'm trying to phrase as predictive knowledge and really try to focus it. If there's basically one thing I want you to try to get into your head, it's this idea of not using the term generalizable knowledge anymore, and instead being more thoughtful on when you're talking about transportable knowledge versus predictive knowledge. And I'll describe that in more detail, what I mean when I say those 2 dimensions. But for now, just basically here, I think we have real opportunity to make a real world impact if we focus a lot more on predictive knowledge and a lot less on transportable knowledge at first. And in particular, a key thing in my mind to remember with this as a subclause is don't assume transportability. Test it using a causal explanatory model or a DAC. And again, I'll come back to this. It probably doesn't make full sense to you right now, these terms, but I will define all of them. And then, so that's basically the first half of the talk. And then the second half of the talk, I want to actually even zoom out more and basically suggest that I think that we actually have great opportunities to do more meaningful work, particularly serving communities and advancing population health. This is more the population health side of this. If we move our methods to focus beyond things only to flows as well, and beyond principles to praxis as well. And again, this doesn't make full sense to you now. I hope it will by the end of the talk. So that's where we're going. Let's start though then, okay, why do I care about this? Let's start with a high level problem. As I look at our world, I think there is an urgent need for individual societal and planetary adaptation. What do I mean about this? I'm sure this is no surprise. There's a variety of health behaviors that we're really struggling with. This is one I've been working on, and particularly when I get to the second half of the talk on the sort of population health side, I'm focusing on childhood obesity. And so there's a variety of health behaviors that I think we struggle to actually facilitate. There's a variety of public health crises. I mean, we were just talking about the gun shootings. Another variation of this is the systemic traumas of adverse childhood events. And again, tag this, the second half of the talk, I'm going to be talking about a multi-scale intervention that I'm co-leading with others, focusing on adverse childhood events and childhood obesity among Latino families. But this huge problem. And then, of course, zoom it out even more, there's the issues of planetary health and the fact that our planet is quite literally losing its capacity to self-regulate and live in the sort of, as people call it, the Goldilocks zones with which our entire societies were formed and assume exist. So it's a time for some major adaptation. And so in my mind, as I think about that, I think, man, there's a huge role for social behavioral sciences, for health sciences, for digital health to do something meaningful. But we aren't producing what we need. And what do I mean when I say that? Well, I think about this in terms of a diminishing returns curve. And I'm sort of asking myself, where are we on this curve? Like, we're putting a lot of time and energy in producing evidence and evidence-based practices and resources. But if we actually look at the meta-analyses and other sort of work, my sense is if we might be here, if not even here, starting to get to negative returns. Well, and why would I make that claim? Well, so particularly from psychological sciences, although I think health sciences, there's been similar things, the notion of the reproducibility crisis. I'm sure you guys have heard this, right? Where basically the predictions we have from our fundamental sciences are not reliably reproducible. Or thinking about our interventions, our treatments. This is the heterogeneity of different interventions. And this isn't in press, I really need to update that. But look up this paper, it's a great paper. But the heterogeneity of our interventions. Basically what it's suggesting is variability is the norm, not the exception, suggesting we can't reliably produce change with the interventions we're building. And then this is a fantastic paper. If you haven't seen this one, just came out by Ken Friedland. This is particularly in the world of behavioral medicine, but there's particularly, I would really invite you to read the online supplement, walking through why using the logic of RCTs and particularly the meta-analyses, it's almost impossible to know if we're making any progress in our science. And so he very much is making an argument for actually focusing a lot more on stepped care and embedding, which very much is in the spirit of what I'm articulating here. But all of these is getting at sort of like, so our concepts are not reliably reproducing, our interventions are not actually reliably producing change, and our capacity using our best standard methods are not actually useful for helping us to know if we're making progress. So methodologically, we've got problems, I think is the short summary statement. And this talk is trying to think, okay, well, if that's the case, what do we do? What should we do? Well, I want to start, I'm going to come back to this figure a few times, but this is zooming way, way out, high level, okay? And this is sort of the second half when I got into that expanding flow to flows and praxis. This is setting that up, but then I'm going to go through two different projects to kind of help you understand this a little bit more. But I want to start with a quote from Rumi. You think because you understand one, you must also understand two, because one and one make two. But you must also understand and. Okay, just let that sink in for a second. And so what does this mean? Well, one way I kind of have been thinking about this, and again, Padja is a close colleague, he and I have talked through this as well, although, you know, we're often arguing, but I think in a very healthy, moving towards the same thing, right? But as I think about health, I don't think about it as an outcome, you know, like think about the WHO definition of health, a state of physical, mental, and social well-being, and not merely a lack of disease or infirmity, you know? And so in my mind, when I think of states, and I start thinking in terms of cycles and dynamics, that to me means adaptive capacity. You could also think homeostasis, allostasis, or you can think self-regulatory systems like the functions of our planet, okay? So in my mind, that's our high level goal is health, which I understand in terms of adaptation and adaptive capacity. So the question is, what is the knowledge products we need to have to help us to get better at improving adaptive capacity of living organism species, including humans, but I would also say the other living species that we rely upon, such as the ecosystems we are a part of. So one way you can conceptualize this is to breaking it up in terms of like trying to understand the system parts and corresponding tools. And then another side, and this is much more of a system science formalism, is the notion of flow of resources, energy, and information within and across systems. Okay, so just have that in your mind for a moment. And then with that, there's different subclasses of methods, from reductive science to system science, which I think we have some awareness of, which I'll unpack in a moment. And then these are the ones that I've been really kind of obsessed with lately: implementation and tuning. Okay, so here I'm at these same things. I'm now putting it into a 2x2 grid, just so you can kind of get back to it. And so what I hope you can see, coming back to this and, is the flow is sort of the question of the and, right? And what I would like to argue is that I think a lot of what we focus on is this one quadrant. And my sense is we need a lot more work in these other areas. So let me try to highlight that a little bit by highlighting, what are the goals in each of these areas? So for reductive science, I think the goal is to create new evidence-based concepts and tools. And we have a lot of resources for this in behavior. This is, I'm a behavioral scientist, so I both from that. So like Orbit and so forth, normal NIH 4A phase clinical trials. Great, that's fine. Build new concepts and tools. I think then there's also an interest in implementing evidence-informed, and notice that slight switched, I switched to informed rather than based, implement evidence-informed concepts and tools. Basically, how do we get these system parts and tools out there and used, right? And so you might think this is the role of implementation science. I'll come back to, I think implementation science is like right on this edge, and I think there's a lot more we can actually do in this dimension on implementation. Notice I didn't call it implementation science. Because why? This is the idea of the praxis. The praxis is basically taking a principle and putting it into the real world, right? So continuing this on, this other dimension is this question of, are you working on the parts of the system or the tools or the things, if you will? Or are you trying to focus on the relationships between those things, the flow? The flow particularly you can think of as resources, energy, or information. 3 core targets within the realm of system science. And so if you're doing system science, you're focusing on principles, and your goal is to create the frameworks and models of how flow works within and between systems. And so there's a lot of great methods with this. The dynamical systems modeling, that's what I do a lot with another close colleague, Daniel Rivera, calls a loop diagramming, complexity science, graph theory, and so forth and so on. But notice here, it's about understanding flow. And then the last one that I would highlight is sort of, well, what if you're focusing on flow, but you're trying to bring it into the world? My colleague MC Schrafel and I have been framing this as tuning. So the notion of cultivating effective flows within and between systems. And you can think about this in terms of like trial and error, intuition, embodied praxis. And then there's other more formalized ways of doing this, like control systems engineering and systems thinking, I think is a really valuable tool for this. But it's really this idea of knowing that, you're just trying to get something to happen in the real world. Okay, so that's the high level frame that I'm going to invite and try to show you and walk you through a few times in this talk. But what I would like to invite you to think about is like, well, what are we actually producing within our science? I would argue we're focusing a lot on all of these different things: behavior change techniques, mechanisms of action, outcomes, contextual variance, and that can be both about people or places. And then also here's, I think, the goal of most implementation science. It's around studying implementation strategies. So that's what each one of these are going for. And so this is great. This is not to negate the importance of this work. My sense, though, is we have so many of these concepts already created that in my mind, Susan Mickey and colleagues are doing exactly the right thing as they're building out this behavior change intervention ontology. If you don't know what this is, it's basically trying to build a really rigorous tool to actually organize what do we know about the system parts and tools. I think it is vitally important. My sense is, though, we keep building in this quadrant and spend less time thinking about this, or even like when we're here working in implementation, we often get drawn into actually the goals of this and not recognize our goal is to actually help people in the real world, coming back to the help people first frame, okay? So I'm going to try to make an argument that we should focus more on these, and I'm going to particularly focus on these 2 boxes the most. But I think system science is great. It's just a different talk that I'm just not giving today at this time. So what I want to walk through is particularly this sort of idea of that Pej and I have been calling Agile science. And I see it very much as a goal is implementation. I don't see it as implementation science personally. And this is a spot where ask Peja, he probably disagrees with me on some of this, so we can get into fun conversations. But for me, this is the spot where our goal is to implement evidence-informed concepts and tools. Okay, and so why? Now let's come back now. Okay, so that's the big high level frame. Take a breath, Now let's get into some weeds, thinking through what does this actually mean? That was the big why. Let's go into some concreteness. So if any of you might have remembered this is a paper that came out a few years now. It was a big JAMA trial about wearable technologies. And for those of you who don't remember it, I'm going to start with actually the media press release. You can see this is how JAMA actually told people to describe it. Use of wearable device does not improve weight loss. And so here's some of the variations of what that came out with. Wearable technology may not help you lose weight. What we suspected about Fitbits all along is true. They're probably not helping you. And then this one is a great, sorry, your fitness tracker is probably useless. And so these are the conclusions coming out of an RCT. Let me unpack what was going on with it and also use this as an example to highlight why I think methodologically, I think we might be struggling because they're kind of making it hard for actually to fill the actual knowledge gaps that we actually need to start making progress. Okay, so what was in this trial? It was basically, well, first, the key thing that they noticed was they were focusing on this notion, at least in the language, they were describing it as a wearable device. So what was that wearable device? It was called a body, it was called a body media armband. So this is what it looked like. A few things to note about it. This device was discontinued before the paper was published, partially because from what I understand, it wasn't that commercially viable. It wasn't very comfortable. It's this big armband that you had to wear on your arm. They actually did this with college students, and they thought this would be a really great way to reduce self-monitoring burden. But in so doing, a lot of the students, particularly women, found it ugly and burdensome, and most people basically just didn't wear it. Okay, so this was the fitness tracker that they say that all the publications basically said confirmed that it was useless, including a Fitbit, considering a Fitbit literally wasn't even studied in it. It was a body media armband that was discontinued. Okay, so this was the thing that was primarily being studied in terms of the digital device. But wait, there's more to unpack this. And let me just be really clear. I think John Jakisik and teams, they did exactly what was right in terms of following the logic of, I think, what we're doing through in terms of pipeline logic. What they were trying to do is they were trying to see is, can we get this? Can we see if this wearable device does better than our current standard of care? And so the key thing they basically did is everybody got a variation of the diabetes prevention program. And if you know the diabetes prevention program, it's basically our standard for weight loss. And one group got the standard of care, which is basically an active self-monitoring. And for any of you that know behavior change techniques, this is a really powerful intervention by itself, right? And so they were trying to see if this low burden one would do better than our current standard of practice. Logically, that makes a lot of sense. We're saying, should we replace what we're currently doing with something else, right? That was basically the question. But it's really important to remember the subtlety here, right? Like, is this saying that this is useless? No, this is actually a really high bar. And second, the really important thing to note, and Pedja and I actually wrote a commentary if you want to dig into like why we critique the hell out of this thing. They had this notion that their core hypothesis was that this was a low burden self-monitoring device. And long story short, if you actually look at their data, most people stopped using it after a few months, even though it was like, I think it was a 12-month trial, if I'm remembering. And so their key concept that it was low burden self-monitoring wasn't actually true. And so I would frame this as more like type 3 error. They basically never studied what they said they wanted to study because they didn't actually get a wearable device that hit the mechanism of action they had in mind for it. Okay, so why am I highlighting this? And what in particular does this highlight into this notion of hope evidence gaps, as I like to frame it? So I think that there's actually 5 of them to really be thinking about, and I think this one demonstrates it. One, I think often we have this hope and prayer that we can reduce health disparities with digital devices, but unfortunately, and I'm going to particularly unpack this more in a second, they often propagate disparities within this. And you can think about this even in terms of that trial. Who was really that for? I mean, there's a small group of folks that could actually get those devices, have it working. There was actually a lot of digital literacy you needed to actually get that intervention to work, to be low burden. Next, we have this hope that they'll have these desired effects like low burden response. But then the actual results, oftentimes we have people not adhering to things. So a clear example, not just in this, but all over the place. And let me just be clear, this is not just this study. I would say these hope evidence exist in a variety of digital devices and interventions. Third, we have this hope that they'll be used in the real world, but they're actually often low adherence and people drop out for them. For those of you who are really interested in just-in-time adaptive interventions and getting the right intervention at the right time with the right person, all that sort of stuff, we have this hope of just-in-time support, right? But oftentimes these tools are actually just disruptive, and so they're just shut off because they're too annoying, right? And then last, we have this hope that things are evidence-based to help us guide the work, but then oftentimes it's poor implementation. And this one, particularly in the world of digital health, has a double-edged sword, because oftentimes the folks who are really good at building tech aren't that good at building the evidence. And those who are really good at building the evidence aren't that good at building the tech. And so this kind of goes both ways in terms of the gaps of this. Okay, so these are the gaps. And what I want to try to make an argument for is focusing more on predictive knowledge, and particularly the way I would think about agile science as we've been evolving it, could help to fill some of these gaps. Okay, and so let's further unpack this by thinking just logically, what are we trying to produce, and is that what we should produce? And so this is you can see a BMC medicine and then a translational behavioral medicine paper. This diagram comes from that. But one way I think you can argue, particularly when you're in the top left quadrant, as we described, the logic that I think is undergirding it is this idea that you're going to produce transportable knowledge. And so now I'm finally getting into the generalizable thing. What do I mean by transportable knowledge? This is probably, when I say transportable, it's probably what you normally think of when you use the word generalizable. It's asking the question of, can I take the insights I learned from here and transport them somewhere else? So this is very much words from Judea Pearl, which I will also come back to in a moment, right? And so you can see it, you run your RCT and you're like, okay, this thing works here, and now I'm going to try to, quote, scale it up, right? So you build this thing, you're saying, yep, it works. You then try to disseminate it to clinics and communities. And then the last step is you hope that that actually helps people. Right? I would argue the entire field of implementation science exists to try to get this pathway to work. And that's valuable. And I think it's important for us to ask those questions. Okay. But I think there's also something very interesting and perhaps some unintended consequences with this logic. Particularly, I want to invite you to think about this and think about how this might map onto the notion of trickle-down economics. So if you're not sure what trickle-down economics, this is particularly the rage in the 80s with Reagan. Some people call it Reaganomics. The idea is basically you give funds to people on the top and everyone should get their cup filled up from it, right? And so this is the hope of what we think it should do. But anyone who's dug into trickle-down economics, this is often how it actually works. We keep pouring things in and the rich basically just get richer, right? So what if our evidence is producing that same thing? What if we basically keep, particularly within digital tools, what if we keep trying to build this out, right? And so I think a good example of this, if you were looking at the FDA pre-certification program, first you can see the different companies that are involved. So this is something the FDA is trying to do to try to bring forth and make it easier to get digital therapeutics out in the real world. I'm not going to go into great depths about this, although I'd be happy to in the discussion section. The key thing I want to highlight is the companies that were involved in the pilot program. It was basically all the rich getting richer. And not only that, when they were running their trials, they were only basically working on the, quote, weird folks. So white, educated, industrialized, rich, and democratic. And so it's a very small segment of people. And like actually Apple did the best, at least in terms of demographic makeup. But if you get into like socioeconomic status or otherwise, there is very limited diversity in these. And these are the spots that are trying to be making claims that this will be transportable to everyone. Okay. And so in my mind, when I think about this, or even I think about like the Jakisik paper, they're both basically starting in some ways with helping the worried well. And if we keep doing that, I think we're setting a very high risk of basically following the pathway of trickle-down economics. We're hoping we'll help people, but we're probably just making the rich get richer, which then will propagate health disparities, which in my view is actually more of the fundamental problem we should all be consciously thinking about. Our normal is bad for lots of people, and our job is to make normal better for everyone, at least in my view. And so you can think about this. This is Milim. She's on this call. So this is actually, we haven't updated one. I should have updated it. But you can think about this in sort of like a continuum of digital device, you know, from a digital device production to evidence generation, which is the one I'm going to focus on here. And then the ones that we often think about in terms of adoption and literacy. But what I'd argue for is that this is a spot, particularly the evidence generation, I think is a key pathway for us to be thinking about. And in my mind, this comes down to thinking pretty differently about the notion of generalization. Okay, so now getting to this, what do I mean when I'm talking about generalization? Well, you can basically think about this in terms of there's two dimensions of this, and this is classic stuff. This is Schottish, Cook, and Campbell, 2002, experimental, quasi-experimental methods. Came right out of that book, right? So, but they didn't use these words, transportable knowledge or predictive knowledge. But you can basically think about generalization in terms of two dimensions, space and time. Okay, so you want to basically figure out, one, did I learn something from this one group, and will this be transportable to someone else? This is the hope and prayer of what frequentist statistics give us. Okay, but there's another type of knowledge, which is predictive knowledge. And this is basically asking the question of, now that I've learned something here, can I use that knowledge to make more informed predictive decisions future? Right. And so you can think about this also, this is more of an idiographic way of thinking about things. It's much more working with time series. And this is where I'm doing a lot of my work, anyone who's dug into my work. So I want to make an argument that a lot of, but also you can use nomothetic, by the way, for predictive knowledge too. It just, you're zooming out your unit of analysis. I'll come back to that. But the key thing here in my mind is your job is to get better at making things work here, now. But as you do that, you start to really learn about complexity in context. So what do I mean by that? And how are we missing that as we think about normal transportable knowledge? Well, this is a classic trial from Bess Marcus. And again, no complaints. Bess did a great work. This is a really solid work. You know, and it's exactly what we want to see in a trial of a physical activity intervention, right? Our intervention worked and it had a significantly different compared to our control. Yay, beautiful. This is what it looks like when you can use nice, clean averages. All the like messiness of life disappears. But is this actually true? Well, now that we have wearables, we know no. And these are not cherry picked. This is data from former postdoc of mine, Guillaume Chavant's, where you can, every dot is basically a different day for a person's physical activity. And you can see variance of physical activity is much more the norm than the exception with people, right? So this is suggesting there's a great deal of complexity. The way I try to summarize this is I sort of start with, I kind of boil it down to this assumption that basically context matters, history time matters, and people adapt to context, and therefore they're different. You can think about this in terms of Mel Hubbell's ones, where there's all these things within the skin influencing you and outside the skin, and then time just keeps on going, right? So the more this is true, the more context matters, history time matters, and the more people adapt to context and therefore are different, the more likely it is that you're dealing with complexity. And the more you're dealing with the complexity, the more and more fragile and brittle our tools for building out interventions become. Why? Because they literally, what is you doing oftentimes with between subjects randomization? You're randomizing out context, history, and individual differences. So if they matter causally, you're not going to even see it in your evidence. Okay. And so that suggests, okay, crap, what do we do? I'm not saying generalization isn't important. I hope you can hear that. I'm saying predictive knowledge as a pathway to generalization is important. How do we get there? And again, going right back to the basics. This is a 20-year-old book, Shadish, Cook, and Campbell. I want to remind you, if you haven't seen this, of the notion of causal descriptive versus causal explanatory models. So causal descriptive, this is basically like flicking a light switch 1,000 times to see if the light turns on. It's all about if there is a relationship. Okay, so, and I want you to link this very clearly to randomized control trials. Randomized control trials are really good at giving us causal descriptive models. And again, that is a valuable part of our toolkit. I'm not negating that. I'm just making sure we know we use it when we actually should use it. That's my main point. So, but with regard to the RCTs. So what's a different thing? Well, you can think about it as a causal explanatory model. This is describing how and why things happen. So if you're trying to understand like why a light bulb turns on, you'd have to have understanding of how like water falls over, down a cliff, it turns a turbine that produces energy, it goes through a bunch of wires, it eventually gets into a house, you close the switch. When you close the switch, you're closing the electric loop that flows into the light bulb. When the light bulb has a tungsten filament, and as tungsten gets electricity going through it, it produces resistance, which produces light. Right? That's a causal explanatory model. And what I'm trying to argue is that when we're doing this type of work, when you're focusing on predictive knowledge, the way you get better at predictive knowledge is actually spending more of your time on causal explanatory models. And I'm not just saying this. This is, I would argue, a logical extension of Judea Pearl. If you don't know, he's like the world leader in causal influence. His arguments around understanding robust causal inference, and he particularly is the inventor of the DAG-directed acyclic graphs, right? But you can think about this in terms of causal descriptive is on rung 2, the doing side of things. And that's the focus of a lot of our work. It's the top left quadrant, I would argue. But I think for getting really robust generalization, both types, you need this causal explanatory. You need real robust counterfactual logic, and you can think about this. You can see Einstein's are on the top of this, right? Like Einstein made such a clear prediction on how much light would bend around a sun that because of the mass, that all we needed was a single observation to prove it right or wrong. That is predictive knowledge, okay? That is saying, can I make a very clear prediction right here? And if you have robust causal explanatory model, you're actually building robust counterfactual logic. Okay, so forget everything. I'm just inviting you to notice the difference between transportable knowledge and predictive knowledge, and then this important role that counterfactual logic places in us, and not just thinking just because we randomize we have counterfactual logic. That is not enough. You actually need to know clearly what your predictions are to, in my view, build robust causal explanatory knowledge. Okay. So if that's what we're talking about, then what does this mean for our science? How do we do this? And is there any role for transportable knowledge? Yes, totally. But in my mind, the pathway to transportable knowledge is through predictive knowledge. And so what that means, though, is we shift. We shift from this to this, where our focus is basically aligning the goals and motivations of researchers, clinicians, and patients to the exact same goal. Help people first with hitting the desired success goals of them. Get good at that in real world complexity, engaging with and meaningfully honoring that complexity. And as we get better and better at that, my hunch is although again, this is a pretty radical departure from, I think, the way we normally do this work. And so just to be clear, this is a hypothesis, but I think it's a pretty well-formed hypothesis. As we get better at understanding and cultivating this causal explanatory knowledge, we can start to actually identify meaningfully the different types of clusters of people or change mechanisms that would matter. And in so doing, we can then actually articulate and test transportability, not assume transportability. And I'll show you why that's really important by the end of this little section. Okay, so this is the pathway now we're going to be talking about for the rest of this talk. And you can also see this very much maps onto idiographic logic, although again, you can also use nomothetic tools and insights. It's just a little bit of a mix. I'll show you more what I mean by that in a moment, particularly with the second one, right? So if that's where we're going down that pathway, how do we do it? Like what's the big why? What are we going for in each phase? Well, in my mind, the big why is doing a nice flip. We often talk about evidence-based decision-making. I think and Bedge and I talk about this notion of decision-based evidence-making to guide real-world impact. So what do we mean by decision-based? This is really saying, know what decision you need to make right now and use evidence to help you make that decision. That's all we're saying. And I think oftentimes we get so sucked into trying to get the evidence-based label that we forget that there are so many decisions that we need to make to even get there. And I think the Jakisik paper is a fantastic example of that, right? Like there was this assumption that it would be really wearable, but it wasn't, right? So there was decisions that were made that were actually not justifiable from the evidence. So how do we produce that evidence? So this is a reframe of this, and you can basically, this kind of roughly maps onto that tool, but it's really, particularly these two phases are really all about helping people. The first step is basically to work with communities and groups, and I would particularly invite all of us to be very conscious of the ways in which who we work with might unintendedly propagate systemic inequities, but work with communities and groups to clearly define success for them and with them and by them, and then the boundary conditions and the constraints. What this does is it allows you to simplify complexity without compromising it, because you don't have to solve every problem for everyone in the world. Instead, you need to figure out, how do I make progress here? How do I build on the assets that are here and build from that, right? So the first stage is basically know what success is and know your constraints. When you have a good working knowledge of that, you can then start working on optimization. This is where you actually try to get solutions that actually achieve the success criteria in context. And this is very much, if you haven't seen the notion of a proof of concept study, this is very much in that sort of spirit. Clearly define, or most multi-phase optimization strategy, the idea is you define success using an optimization criteria that you can judge from your trial. So it's basically like, if we get 80% of our sample to lose, 10 pounds or whatever you might want to set, right? Great, you've hit your benchmark, you can move forward. You can set, of course, you have to meaningfully justify those outcomes, right? But that's the sort of logic you can judge yourself on. And you can know, if you don't get there, you have to go back to the drawing board. You might need to recreate your boundaries or understanding or solutions, but this is sort of the pathway. And then I'll get to this later on the transportable side of this. But so this is where we're talking about right now. And so now, to give you another visualization of this, and these three visuals are all kind of linked together, just to be clear, this would be another way of visualizing. So you can think this first one is all about here, how you do this. The second one is all about this, or the optimize, it's in these circles, right? And then the last one, transportable, this is sort of the market expansion. This is asking transportability questions. Okay, so I'm going to now unpack this. And again, this is the figure that Lynn had developed and that we're working on to try to articulate, what do we mean when we're saying agile science? I'm like, what is developed? How is it developed? Okay, let's start here. So what are you doing with this? And so this is the project I'm going to describe. I've been working very closely with Family Health Centers of San Diego. They are the largest federally qualified health service in San Diego County, a fantastic group. And so we've been working on a variety of projects. This is actually the second project, but I was also, the first idea actually grew out of it, and we're using a similar methodology actually for it, particularly for this sort of phase one development work. What are we doing? You can think about this as basically, if anyone knows Greg Aarons' EPIS framework, exploration, preparation, implementation, sustainment, we're very much, I really like that as a concept, although we're really trying to push it even harder. And Greg, by the way, I hope you can see, is actually a co-I, or actually an MPI on that other project that I'll describe in a moment, right? But the idea here is like you're really trying to focus on defining success, right? So this is very much CBPR-like, right? Co-develop success criteria, assets, needs, and understanding. Build on what already is happening. What are already the practices? You don't have to bring something new. Build on something that already exists. And then from that, the advocacy, that's actually in the second one. That's less in this first one. But basically, like, build on what already exists. Know what's going on, the exploration phase. From that, you can prepare by trying to figure out this sort of decision-based evidence making. What's the evidence and what's the tools and what's the resources that we need to do to try to make progress to hit the success criteria using the resources that we have to do that, right? And then from that, you can then run up optimization, trial and sustainment, which I'll show a little bit more later, right? So with this, one of the first things that we worked on, particularly in family health centers, we were focusing on both adverse child events and childhood obesity. That's the second project. But there was a separate thing that Job and I and others started working on, which was actually on hypertension management with digital devices. And so, long story short, we actually realized that actually a microanimization trial could be a really valuable intervention, and I'll describe that to you in a moment. But we basically had this clear set of success criteria of improving hypertension management, particularly among African-American communities within who receive services at family health centers. We saw that there was actually an opportunity. They actually have a large amount of funds where they can buy digital devices for folks. So there's the assets. We had the success criteria. The problem was we didn't know how to actually meaningfully deliver it. Okay. And so we came up with, so we had the success criteria, we had assets, we had constraints, and then we thought, okay, what do we need to optimize? We need to optimize how the digital devices and the care that already exists will be delivered. And so for us, this became a microanimization trial, although I hope you can see here, there's a variety of tools you can use. Factorial trial, smart, like this is very much most with the focus on implementation. You know, can we optimize it to get something to work here? Okay. And you can produce, this is coming back to the Agile Science paper, there's a variety of products you can actually build, right? From minimum viable products to adaptation algorithms to the intervention components and so forth and so on. So what are we doing here? Well, I think you guys probably just heard about a microanimization trial. So I'm actually going to kind of skip through this, right? You can multiple randomize. You just heard that talk. You might have heard about this. Like this was basically the trial that, you know, Pej and I'm just assuming since you just went through Walter's talk that you probably have some sense of this, right? But the key take home I would want to invite is, you know, when you're doing microanimization trials, you can get a lot of insights about the hope evidence gaps, you know, so you can answer, does this work? This little notification, it works on average, but it had diminishing effects, right? We also had implementation intentions. That one seemed to work the whole time. We also had time ring effects, particularly the implementation science, the implementation intentions, which is basically asking people each morning to write a plan. That worked really, really well only on weekdays and only if we actually had people fully fill it out. If they just had to select from an option, it didn't work, right? So this gave us really subtle insights to improve adherence, to improve outcomes, and to give us the sort of rich evidence that actually helps us to design robust tools, okay? So this is the sort of thing we're thinking about. And I think it could really be valuable for filling in these hope evidence gaps. What we're doing, and coming back to Job, right? We actually have this, it's a proposed MRT. We haven't actually gotten funding for it yet, but this is we're working on this. We're hoping we'll get funded for this, right? Where basically we were really realizing that the key gaps were on, there was struggles with medication adherence. And then also it was unclear, telehealth is the more expensive tool. The question was really doing this treatment match of when and where do telehealth really produce the effects that we need for it. And so this is actually very much, we're trying to optimize and do basically really rigorous quality improvement within family health centers, okay? So microanimization trials, we're trying to get better at predictive knowledge. We're trying to figure out how do we make it work here, right? But I hope as you can see, as we're doing this, we're engaging with complexities, real world complexities. What are the actual assets? And from that, I think we're starting to, and moving towards building out these causal exploratory models, which I'm increasingly starting to call as system maps, but that's more just using the system science language, but like there's similarities there that are important, or subtleties, but that for now, just don't worry about it. But it's allowing us to start build that rich knowledge of how things actually work in the real world, basically, okay? And then with that, we can start asking this third question, which is basically, how do I get this to work somewhere else? Will it work somewhere else? And this is where I think the most critical thing is for us to actually ask that question and test it, not assume it, just because our methods have in the past allowed us to make that assumption. And this is basically where this comes into play. This is where the transportable knowledge is coming into play here, okay? It's in these final stages here. And so just to quickly run through this, I'm not going to have a chance to really go into depth because I want to get into the other one. I'm realizing I'm going a little short. If anyone hasn't seen Reaim, particularly Russ Glasgow's thing, like this is really important. Basically, we had this huge drop off, even if like these are actually very ambitious assumptions that 50% of a setting that could use something actually use it, 50% of the staff who actually might use it are valuable, right? So forth and so on, to the point where when we actually get to an effect, there's going to be a very small impact if we're following that cascade of effects, right? And so this, to me, just from a logical perspective, and then you can look at the evidence on how poor we are at actually getting anything to implement, right? The notion that we can assume transportability from an RCT, in my mind, is insane. Instead, what we need to do is actually test it. And how do you do that? Using a causal explanatory model to guide your hypothesis of transportability. So here's a very, very simple one. And by the way, if you know a directed acyclic graph, this is definitely in that spirit, right? So I'm just adding one potential causal variable that, of course, we can't randomize, socioeconomic status. And I'm basically hypothesizing that it will have an impact on the number of people we enroll, the amount of adherence people will have, and ultimately on weight loss. And so what does this mean? Here are the hypotheses, right? Socioeconomic status will have an impact on the percent of individuals who will enroll among those contacted for the study. Individuals with low versus medium versus high will have significantly different enrollments among those contacted. Notice this is literally never picked up in the FDA work, right? But it's also not picked up in general. This is something we don't actually have to test because we don't have a causal explanatory model of key factors driving and dictating what we're actually hypothesizing about transportability. But this gets, and that's probably the most one we're blind to, but then you could even think about this in terms of adherence and then even in terms of impact. You know, and I think as you see this, you're like, oh yeah, right. If you actually had really meaningful levels of these, the fact that we probably would get differential response is hugely important, but largely absent from our current thinking. And I would say it's because we have an underspecified understanding around transportability, and that we should incorporate that as actually part of our science, but focus on predictive knowledge first, because basically, one, it's easier, but two, it actually aligns the motivations of scientists, clinicians, and people. We're all working for the same thing. Can we help you live a better life? Okay, so that's kind of getting into that. So this is the basic summary here. And this was basically this agile science argument. Now, I do not have nearly enough time to go into the second one, but let me try to get to so just to kind of hit on my take home arguments, this is what I've covered. Basically, I think we should be focusing on helping real people first. And we do that by focusing on predictive knowledge over transportable knowledge. And then we actually test transportability rather than assume it. Okay, now I want to get back into these broader ranges. So very quickly, because I don't have enough time, and I want to at least have a few minutes for conversation. I have another project that I'm working on. This is funded by the California Initiative for the Advancement of Precision Medicine. And long story short, we're actually trying to basically synergize our methods by consciously using each one of those lenses to actually guide the study that we're developing together. So I already brought this up. This is about adverse child events. It's a really hard thing to treat. Our core goal is basically to build this, take this notion of predictive knowledge. I see us as not producing transportable knowledge here per se, although that we might get that as a side benefit. But my main goal is to basically get better at helping people in San Diego who receive services from family health centers. And so we're working on this using 3 different lenses simultaneously. We're guided, I don't have time to get into this, but we're guided by a model the key thing to note here is basically from a system science perspective, we are starting from the assumption that we're monitoring flows, right? This is basically monitoring the flow of energy of the type of energetic potential that increases someone's risk of a trauma, which we're defining as a compromised safety, belonging, dignity, or mattering, okay? Which can happen both individually and systemically. Okay, and so this is the flow of information, a flow theory of trauma, if you will. Okay, so with this, we've developed a multi-level intervention. So first, we started with the assets that already exist within family health centers. It's called the Healthy Together program. It was a weight loss program where it basically includes monthly navigation for social determinants of health, for support with food insecurity, housing, poverty, and weight management. And then also this regular meeting with dietitians and physical therapists. What we've added on to this project is parenting training, particularly building on elements of Incredible Years, although we're not actually implementing Incredible Years, we're pulling materials from it. And then also promotoras or community health workers, providing that added support. And these are the targets of our 2x2 factorial. And this is the target to help with the individual trauma loop, if you will. We've also added in a systems level where what we do is we're having families actually getting trained in how to basically do advocacy work for themselves. And I don't have nearly enough time to get into all of this, but in brief, I want to give a shout out to my colleague Antonia Colm and Ikta and Tessa and others who built this tool, really great tool called Streetwise. It's basically like Yelp meets photo voice meets social determinants of health, right? And so it's allowing communities to describe the places and their places and describe what's the good things, the bad things, things that need to be fixed. And what we've been doing in San Diego is actually having people describe the good things and bad things and things that need to be fixed in their areas. And in so doing, we're building this rich multi-level data about the social context with which people live. And in so doing, it's part of, and then from this, we're part of the Childhood Obesity Initiative, which is the largest collective impact model in the country. And we have been creating what we call a community council, which is basically a pathway for these data to be directly fed into doing advocacy work. And literally, like Supervisor Vargas here in San Diego County is the champion for this. She's literally listening right into this to sort of think through key policy recommendations and decisions for her to advocate at the county level and even potentially be elevated to state and federally. So we have this pathway for influencing the systemic inequities built in, and our patients, basically, they will be given first in one session access to use it and to document the good things and bad things of their areas. And then in a later section, checked in on say, okay, now that you've done that, tell us about it and tell us what we should be advocating for you to try to reduce systemic inequities. Okay, so that's our multi-level intervention. With this, we are actually using three synergistic approaches. One is a traditional 2x2 factorial trial. And so this is basically, we have parenting support or not, promotor support, everyone's getting healthy together and that family streetwise. We're focusing on the parent's assessment of protective factors as our primary outcome, childhood BMI is secondary. And we're looking for a variety of secondary markers to help us basically make a robust argument on stepped care. And I see this as basically like a really good starting point to then hopefully inform a SMART trial, sequential multiple assignment randomized trial, to study the stepped care decision-making. So that's one. Two, we're doing an extension of EPIS, this implementation. And I really think about this as rigorous quality improvement. Can we get something to work here? So this is the original EPIS framework. This is the extension that I already showed with you before, and I kind of talked through with this sort of preparation work, right? And so where we're going with this one in particular, as I said, is we have this healing-centered relationships, a 2x2 factorial, but we also have a quasi-experimental experiment going on because we have 4 clinics that are getting it versus 6 controls. So we'll actually be comparing these outcomes between the different clinic sites. And then we have this community advocacy layer for this, right? And central to this from the sustainment perspective is we've been really, really mindful on, can we produce evidence from this RCT that would be useful for helping FHC, family health centers, decide what is our standard of care, because they're not actually sure. And so another way you can conceptualize each one of our conditions is almost like their own little proof of concept studies. We have clear benchmarks on how much, what is, I think it was 1 standard deviation improvement for protective factors. I forgot the exact amount for adherence to, but basically we need a certain number of billable hours to make this worth, to actually cost effective. So that's built into our optimization function for our proof of concept. And the idea is basically if any one of the 4 conditions hit that mark, that will automatically allow us to justify saying, yep, it's getting clinically meaningful outcomes in this context. And 2, it is implementable because we have the funds actually balancing it out, right? And so that is built into our entire trial such that this, if we get the benchmark, could immediately be sustained with current funds from family health centers. So that was built into our logic from the get-go, and this is coming back to help people first. Okay. And so the last thing I want to highlight, but we're running out of time, is the notion that you can also think about this from a tuning perspective and systems thinking. And so if you haven't read this book, it's really great. Donella Meadows' book of Thinking in Systems. And this is a later chapter. She's talking about the notion of leverage points within systems. And I, again, don't have time to get into the depths, but what I wanted to invite you to do is notice number 12. What number 12 is basically talking about is interventions and concepts. This is the focus of the upper left-hand quadrant. Okay. And I hope you can see, and from a systems science perspective, this is probably the least important target for us to be working on. They can be very valuable, though, as long as you're using them in the service of higher leverage points. And the ones that we're focusing on in particular are these. Reinforcing feedback loops. You can see we're basically trying to counteract this compounding reinforcing feedback loop. We're increasing information flows by trying to get that which is currently invisible and from to visible through Streetwise, and then brought right in for advocacies for systemic inequities. And last, I didn't get enough chance to talk about this. We're spending a lot of time thinking about cultivating healing-centered relationships, such that at the core of this, everyone's basically being trained in attachment theory. I'm like, how do you actually know that all dynamics is around trying to understand how do we know that we're constantly going to rupture relationships with each other, and we need to know how to repair them. And so working on creating those healing-centered relationships between the parents and the promotoras and the navigator, between the navigator and promotora, between them and the healthcare system, all of that is undergirding a lot of our implementation goals. And you could frame that almost as the implementation science, the implementation strategies that we're trying to implement. Okay. And so what you can see here is we're actually using 3 different lenses within one trial. And we're actually moving towards this one because now I'm starting the systems mapping basically, but I didn't have it ready for this talk. But in so doing, I hope you can see from this, we're consciously working on both the system parts and tools and paying attention to the flow of resources, energy, and information. Because in my sense, we need to actually understand all of that if we actually want to advance health, adaptive capacity. So just to summarize, this is a huge project. I particularly want to give a shout out to Gary Firestein, who is the contact PEI for this, and others for this really great work, or important work. So here's the summary statement of my talk. Hope evidence gaps exist with digital therapeutics and community and population health generally. What do? Let's help real people first by creating and optimizing interventions in partnership with communities and those serving under-resourced communities. Use the methods, particularly from MOST and others, to improve real-world impact by focusing on the predictive knowledge over transportable knowledge first. And let's not fall into this trap that we've allowed ourselves to do, which is assume transportability. Let's test it, consciously test it. And then with this, I hope you can see that I think there's actually, I tend to hate the phrase outside of the box thinking, but I think this is a time to actually get in some outside of the box thinking. I think there's a lot more than just creating concepts and tools. I think there's a lot to be said for implementation, tuning, and system science. And I would invite us all to more meaningfully engage in those, even just taking it from like using those lenses in the trials and methods we're doing right now as a starting point. Thank you.
Thanks so much, Eric. As usual, it would take me, watching this at least 5 more times to understand what the hell he was talking about. But it was
That's
also
how I give my
questions. Questions for Eric.
Or it's the end of the day and I just confused y'all and you can watch it later too, which is fine. Yeah, you guys have been on Zoom for 4 hours, so I'm sure that was just too much, but that's fine.
I just wanted to say that I think it's a lot to absorb. I found it very interesting, and I've been thinking about my own study and to see what are I'm missing, but what are the points I'm hitting. So I just want to hope to comment that this is very helpful.
Thank you, I appreciate that.
Maybe I can just then ask a question. Just given this audience, Eric, if you were to synthesize your talk into a 2-minute pitch of how you would do mobile health research differently, especially intervention research, what would you say? Like, summarizing what you've done. Someone is starting out to build a mobile health intervention. Pick a health domain of your choosing. Obesity management. What do we do? And how is it different than what we would traditionally do?
Yeah, great question. And I think the summary statement for me is focus on helping real people. And so what that means is know that here's what I think we often do. We often try to build out a tool or an intervention, and then we just recruit whoever will come to our trial, right? Because that's a logic that makes a lot of sense from a transportability narrative and logic, right? What I'm saying we do instead is we say consciously, and we know consciously that there's a community or group that we're meaningfully trying to serve, and we try to work with them in partnership to actually make progress with them, co-define those success criteria, and then build the evidence with them. And so for me, like working with federally qualified health services and meaningfully try to help them, like I think about it more in terms of like, if we got better at rigorous quality of improvement, I think we would also get better at really meaningfully engaging in complexities. And in so doing, I think actually start one, actually hopefully helping to actually get things to work in real world contexts, but then 2, actually start to learn about these complexities, which I think is actually the pathway to what we all want, which is this. I totally want transportable knowledge. I just think it's a hell of a lot harder than we've assumed it is.
So let's push that just a little bit more. So, I mean, what you've described so far, one just playing a devil's advocate, I would say, well, isn't that what community-based participatory research folks do, right? You're doing something different, right? And the different piece, I think, is the causal logic that then gets added to this to try to get. So can you speak to that just a little bit more? For myself being slow and for the rest of the folks on the call who've been on this for the last 6 hours.
Yeah, that's a great question. And that's exactly right? It's basically like, I'm not letting go of causality. I hope everyone heard that. I'm not letting go of generalization at all. I'm just saying, let's focus on the predictive knowledge. And so that's exactly right. It's like, for me, everything is coming back to building those causal explanatory models or those system maps of what's actually happening here, and knowing that that's something that we're constantly refining. And through that, we're starting to articulate our understanding and capacities to predict. And so you can do that very simply with just simple little diagrams, right? Or you can get really complex, which is where the system science starts coming into play with computational modeling and otherwise, right? I don't think you need to jump to computational modeling, which is why I didn't get into it at all. But that's the logical path that this is taking you towards, right? Or eventually you can actually manage and deal with complexity in a meaningful way. But it's trying to I would think about it in many ways as sort of marrying the logic of system science with participatory action research and participatory action and rigorous quality improvement. If we can bring those two things together, I think we can get the balancing act of actually helping real people and actually managing the complexity in a meaningful way.
Cool.
I have a question. So one of the things that kind of when I've explored thinking about how, we're designing interventions to help communities versus kind of this approach of we're showing up, we've got our study design, we've got our intervention. What do we say when we're trying to pitch this to funding bodies? Like if I tell a funding body, I'm going to go do a year of work working with this community, we're going to figure out what the questions are, what the really needs are, they're going to laugh at me. Versus, when I apply for NIH, here's the plan, here's a picture of what the app's going to look like. They like that. So it seems sometimes that our funding bodies hold that type of work in tension. And so I'm kind of wondering what techniques or what approaches you have where we can bring in these elements or we can get funding to support that type of work so that then we can actually do the things we want to do.
Yeah, a few comments on that. One, you're exactly right, totally. And it's really depressing. And it's not as true as I think you think, though. It's sort of the short summary I would say is groupthink is really big on us, right? It's my experience with program officers is a lot of program officers are very much supportive of this logic. And I work with a lot of different institutes from NHLBI, NCI, NIA, NLM, all of these folks have funded me. So, the experience I have, and as I've been thinking about this, is it's less about the program officer and it's more about the study sections. And so the second thing is my experience with study sections is what you need to do is you need to know that they have a checklist in mind, and you need to give them that checklist, right? And so I think the real difficulty is right now, I think a lot of study sections kind of conflate the notion of intervention study with efficacy trial. Thankfully, I think with micro-randomization trials and MOST and Orbit and otherwise, there's getting more and more flexibility that are kind of coming out on how to do this, right? And so the strategy I often use, particularly when it comes to funding, is basically innovate once, right? And so it's not like CBPR doesn't exist, right? Like there are, and this is also why I would invite you to look at EPIS as a framework, right? EPIS exists. We're following that as an implementation science strategy, but we're doing it not for implementation science, we're doing it for implementation, period, right? Because then you get into hybrid clinical trials and all of it's about the implementation strategies, and we don't have any time to get into that right now, right? But like the short summary is like you can often take a concept that already exists and that you can reference and say, here, this is the checklist I want you to follow. And here, this is the way I've tweaked it in one way to get me to do what I want to do. And in so doing, you can often get it through. You have to be very careful with your study section, though. The study section is the most important thing. It's not about the program officer. It's all about study sections and what they understand. And so you want to find the ones that has a checklist that's close to yours, tweak it in one way, and implement. And I think there is a way to actually do what I was describing, particularly I'm like National Institutes of Minority and Health Disparities Research, right? This is very much in the style of RFAs and RFPs that they've been putting out. And so, that's the short, and I know we're past time, so.
Well, thank you so much. This was wonderful. Thank you all for hanging on this long and for your attention, really engaged discussions throughout the whole day. Hopefully the rest of the seminar of the Training Institute will go just as well. Wishing you a good rest of the week, and we'll see you in your sandboxes next Monday. Thanks so much.
Bye all. Thank you.
Bye.
Thanks, Majid.
Thank you.
Of course.